Good morning. This is Tina Drago with Healthy Las Vegas coming to you on KDON Studio A. Today we have Matt Engstrom. He is back to finish up our conversation on Medicare. Our conversation last week was talking about the different types of Medicare, right?
Yes.
And so we know now that there are 3 different types of Medicare.
Good way to look at it, yes.
Yes, I figure that's the best way. Give us the 3 real quick.
Okay, original Medicare. Mm-hmm. Original Medicare with a Medicare supplement. Medicare supplement is also known as a Medigap. Then there's Medicare Advantage.
What about prescriptions?
Well, we'll get to that in a second.
Okay, because that's a whole nother area, right?
It's a whole nother topic, I'd say. But when you talk about what you're gaining versus what you're losing and vice versa, whatever Medicare itself would cover or approve, the Medicare Advantage organizations have to cover and approve.
But they do it with a closed network, don't they?
They do.
Okay.
They do. So just from a financial standpoint and not a financial standpoint, but from a coverage perspective, nothing is lost.
Okay.
So what are the benefits that people look at? It's probably something we want to get into. We talked last show about how great original Medicare is by itself, but there are some concerns financially. There's deductibles, there's co-insurance you have to be mindful of. With most Medicare Advantage plans, the immediate gain that you have is you're going to be able to predict or better predict your financial exposure when you get health care. Meaning, most health plans, most Medicare Advantage plans are going to have copays. A lot don't have deductibles. And in some cases, there's only a little bit of co-insurance. Okay. So in most plans, in most parts of the country, you can look at your book, what we call your summary of benefits, and you know if you're going to see a specialist, you'll pay X amount of dollars. If you see a primary, X amount of dollars. You'll know ahead of time what your costs are going to be. And that's a really important thing because you're talking earlier about budgets and limited income.
We're all on a budget when we retire.
Yeah.
I don't care how rich you are. There's a budget involved.
Everybody. Whether you acknowledge it or not, you probably should have your own budget. But that's the biggest thing, I think, number one. And then you mentioned networks or a closed network earlier. So now in 2015, what you're going to see and what you'll continue to see is most Medicare Advantage plans are going to be an HMO. Okay. So you'll have a defined list of doctors and hospitals that you use for scheduled care. And that's a really important thing to emphasize. For scheduled care, you must adhere to the network, see their doctors, their specialists, their hospitals. If it's an emergency, it doesn't matter.
Okay, so this is something really important, my listenership, that you should really grasp, is that if you have a doctor that you enjoy and you're looking now at Medicare Advantage programs, you need to talk to that doctor and find out what they accept. Yep. And also ask the Advantage programs what their provider base is. They will give you a list. Usually it's on the internet. They'll have a list of their providers and you can narrow it down by zip code or you can narrow it down by specialists. And you can actually peruse them and look at who their providers are before you make that decision. Nothing's worse than making a decision about going with an insurance company and then you lose your medical staff.
True. And one thing I'd like to add to that is that what I've seen in my 11 years of being in this business is that a lot of companies, they tend to sell or market prospects based on the size of the network. So I'm company XYZ and I've got 1,000 different physicians in my network. And understandably, some people become enamored with that. They go, oh, wow, you guys have 1,000 doctors. That's great.
Yeah, I can get in any time to see somebody.
Here's my question. How many doctors do you need?
Exactly.
You need one good primary, one good personal doc. Then depending on your circumstances, you may need some specialists, maybe not. But what the way we counsel folks on this issue and we help them do their research is it's not necessarily the quantity of doctors, it's more the quality.
That's very true. Because at First Person, we have very high quality doctors.
I've heard that, yes. but that's a big thing.
And it's funny is don't be afraid to ask your provider. Don't be afraid to ask your office manager what insurances they take and the value, because they're going to be the first ones to know, yes, you can keep your services. Right. Yes, you can keep what we're doing here. If you're on any programs or doing any procedures with your provider, they're going to know right away who will cover it and who won't.
Yes.
So that's something you should involve your provider in, especially if you have a close relationship with them and you want to maintain. If you're looking to jump ship and you need an excuse,
there you go.
There you go. Yeah, but you can always talk to your provider and they'll let you know.
So there is one other caveat I think we need to let your listeners know about with Medicare Advantage. So I mentioned most plans these days are HMO. And that's going to continue because there is a huge push towards preventive care.
Now, to me, HMO is a 4-letter word. So
Doesn't have to be.
And it's the truth of it is because there was kind of this abuse.
Oh, yes.
Early on, and you were kind of controlled and told what you couldn't do. But the truth of the matter is, a true HMO just means it's a limited network. Of agreements that the insurance company has in place with the providers. It's not supposed to be a control factor for the patient.
No, and to your point, the HMO or the concept of an HMO, especially in the 90s, went a little bit south. I remember vividly, I was, I don't know how old I was at this time, but this was in the late 80s. And
so
I
you're
got
like 5?
Something like that. And I got my first pair of glasses.
Yeah.
Or no, I tried to get my first pair of glasses. And we had an HMO at the time through my parents' insurance, and it took me a month. And I remember thinking, why do I have to wait? And I'm young. I just my first pair of glasses. I don't know what's going on. All I know is I have a chance to see clearly, and I have to wait a month. And I just remember these conversations, this rigmarole back and forth with my dad and the insurance company. Those types of things that you're alluding to, and I experienced, they were pretty common back then. But we're not in the 90s anymore. We're in 2015. And so what I tell people is, if you have that 4-letter connotation like you mentioned, the HMOs back then were more profit driven.
Yes.
If we can say that. Whereas now, profits for most companies always a target or a concern. But nowadays, the focus and the pressure, if you want to call it that, is on the outcomes.
So here we went from quick money to long-term money.
Yes.
Because back then, they didn't want to give you any of the benefits to take care of yourself for the long term. They were looking at the quick dollar.
Yep.
And now they realize, it bit them in the butt, that they need to give people their annual visits and they need to take care of their primary issues and they need to educate and they need to work with them so that they can have a longer, healthier life.
And it used to be, I guess, that denying or delaying care would make the company money. But what most HMOs are now understanding is, to your point, if we're focusing on prevention, if we're coordinating care, which is the benefit of having a selective or limited network, if all those things take place, patients should get healthy or they should stay healthy, then the companies can make their bottom line. They can make their dollars. One component, though, of an HMO that I think we probably want to clear up for the listeners is the notion of referrals and the notion of authorization.
Oh, that's a good point.
Yeah. And it's one that comes with some confusion and some hesitation sometimes. So with original Medicare and also with a Medicare supplement, you're free to go wherever you want. No referrals, no authorizations. In most cases, you just go see the doctor you need to see, and that's it.
And as they say on that T-shirt, freedom isn't free.
Right, exactly.
Right?
That freedom that we're alluding to comes in the form of higher copays or higher costs, rather.
Exactly.
So with an HMO, there may be referrals. There may be authorizations. Now, what's the difference between a referral and an authorization? So a referral is when somebody like your primary care doctor refers you to, say, a cardiologist.
Right. We'll have that from time to time at first person, and we'll say that this person has an irregular heartbeat or their EKG is off.
Yes.
And we want a cardiologist for a second.
And that's just a formal suggestion, I guess, where they refer you, and I'm using air quotes for the listeners, they'll refer you to that cardiologist or to that specialist. An authorization is different. So let's say that I've seen my primary care doctor at First Person Care Clinic. They refer me to a cardiologist. Now, my cardiologist says, Matt, you need to have, a stent put in, for example. That specialist is most likely going to submit an authorization request or an authorization for approval.
Called a prior authorization, too?
In many cases, yeah. What that is the effort and the need to make sure that the procedure that my cardiologist is recommending or requesting is medically appropriate for my condition.
And listeners, this is done every single day, whether you know it or not. These pre-authorizations are done with pharmaceuticals. These pre-authorizations are done with referrals. Because as a specialist, I have to say, this is the reason why, and provide soap notes and provide information. And in all honesty, it protects the patient. Make sure you don't have a rogue or experimental specialist out there.
Don't want one of those.
It protects the high costs of the program, so your premiums stay reasonable. And if it's meant to be, if you need to have it done, nobody's going to deny that.
No. And the ultimate goal, I think, with, and I'm speaking on behalf of all insurance companies, but in my experience, I think the ultimate goal of having referrals and authorizations in place is to make sure that the best care possible is going to be administered to those patients. And when you have a limited, or we call it a selective network, a limited list of doctors and hospitals, when you have that smaller list of providers to deal with or to work with, you tend to have better collaboration and better communication.
Yes, the communication's huge.
Yeah, and that's, we've talked about that before on and off air, but communication in healthcare is really the biggest challenge that anybody has.
I have to tell you from the provider's point of view that when I'm looking for a pre-authorization or I'm dealing with my insurance company, I don't want to sit on hold for 45 minutes because I'm one of 300 different primary care providers in Las Vegas that's authorized with them. I want my rep to be able to talk to them and be able to make sure that my patient gets the care they need. And that's the upside of the selective network.
Right. And to your point, you don't have to sit on hold while you're trying to check the status of a referral or of an authorization. In some cases, you have your own website, a member portal that you can access. But the reason I want to stress this is, A, I wanted to clarify what it is and what they are. But B, most of the time, when you're talking about a referral or an authorization, there's little to no work on behalf of the member. It's all done by the providers.
Yes.
But we have this connotation or this I don't know what the word would be, but this impression, I guess, that sometimes the member has to do the work. Like they have to take the referral and they've got to fax or they've got to do the authorization themselves. That doesn't happen. It's
so
all
here's
done
my
provided.
PSA, right?
Yeah.
If your doctor tells you, here, call this doctor, get another doctor.
Yeah. Maybe call First Person Care Clinics.
Yeah. The doctor is supposed to call the other place and set up the referral. Now, he may say to you, I'm going to refer you to Dr. ABC.
Yep.
And then if you want to call in a couple days to set up an appointment, that's good for you. If they don't call you, then that's a different story. But they'll never make you make your own referral.
It should never be on your desk or your lap. So I think that's important though to talk about with the HMOs, because there are a lot of folks right now that are boomers. They're turning 65 soon, and they may have had experience or they may have heard about the HMOs of the 90s, and that's not the way it is today.
So what are some of these? Now, I know CareMore has a care center.
Yes.
And I know Dignity talks about a program, I think, and there's some other places that have it. What are these care centers, and why would somebody choose a program, an Advantage program, that had additional centers out there?
So I'll give you the same answer I give to the general public when we're out in the community and we're talking to folks and we're explaining what CareMore does. What we tell them is, no matter what company you're looking at, including CareMore, no matter what company you look at, you're going to find that there are always two things that are the same. Always. Every company is going to tell you or dictate what your access to care is. They'll tell you what providers you can see, what hospitals you can go to. Everybody does that in one form or another. Number two, every company is going to give you a list of benefits. What's your copay to see your doctor? What's your cost for your prescription? Every single company does these two things in one form or another. Now, there are differences between the copays and between the networks when you look at the different plans, but for this example, every single company does these two things.
Okay.
So the question then becomes, beyond these two things.
Yeah, what separates the men from the boys type thing, yes.
So some companies give you access to a gym membership. It's a great example. Most organizations these days partner with organizations like Silver Sneakers or Silver and Fit is another organization. And what they do is they pay these companies a monthly fee, and then in return, the members of that plan have access to a gym for free, for nothing. They don't have to pay for it.
Okay, I pay for a gym and I still don't go.
And that's where I'm going with this. A lot of these companies, including us, will give you access to the gym, but very, very few people use it. So the question is, what good is that gym if you don't go? I
got to tell you, I'm pushing the sunny side of 50, and here, the last thing I want to see is when I go in there in my sweatpants and my bandana on my head is some tight little 20-year-old running circles around me. I'm depressed as it is.
Well, we can talk off air about that.
I just want, I want to be healthy, but I don't think that's necessarily the motivation for a mature audience.
Well, I can get to that in a minute, but just to kind of help explain what makes us different. I mentioned these two things that every company does. So I always tell folks, look outside these two things. What are you getting beyond that? And with us, with CareMore, what we're doing is we're adding a healthcare delivery model on top of the network and on top of your benefits. And this is very, very crucial because CareMore was run and founded, actually is still run today by physicians. So although we are an insurance company, we are a competitor to Humana, we're a competitor to United and the others, we have this clinical component that works in addition to our network, in addition to our benefits.
So you listen to your patients?
And we talk to their doctors, their primary care doctors.
Excellent. Okay.
Our focus is prevention, managing chronic conditions, and coordination of care.
And it's the chronic conditions that are the gateway to so many other issues.
Without question. And what I tell folks is, when people ask us, well, what do you mean by managing chronic conditions? The example I give is somebody who was just recently diagnosed as diabetic. This happened to a member of my family recently, and she went to the doctor. The doctor sat her down and said, well, based on these results, I'm going to have to diagnose you as having type 2 diabetes. So she proceeds to ask a few questions. Mm-hmm. And essentially what happened was that time was up with that doctor. And he says, here's a pamphlet.
Nothing irks me more than that, because that's a scary diagnosis.
And here's what happens most of the time. Most people have this same experience. You know what, Tina, I would love to talk more about this, but I got to get to my next patient. Here's a pamphlet. Here's a number. Go take a class. Maybe I'll give you a book suggestion from the Oprah Book Club, whatever it may be. But right out of the gate, most folks aren't getting that immediate support and education.
And you know what that tells me? The doctor doesn't know enough.
It's one of two things. They don't know enough, or they don't have time.
If they don't have time, they don't care.
True. So take this example. Now you got this new person, or new diagnosis for this person. They're not getting the education or support right from the jump. If they don't have the initiative or the wherewithal to figure out their disease and how to manage it on their own, that disease or that condition ends up managing their life for them.
Yeah, because the first thing you know is, okay, I've got to change my eating style. But you don't know what exactly you have to do to change your eating style.
No.
And honestly, every person that gets diagnosed with COPD, hypertension, diabetes, or any of these other chronic diseases, they go through a depression. And if you don't, you're fooling yourself.
Yeah.
Because this is a life cycle big change for people. And now you're just kind of going along minding your own business, and the brakes are put on and you have to change things, and it's going to affect you psychologically, emotionally, as well as physically. And you really need somebody to wrap their arms around you and help you with this.
Yeah. And so for folks...
Because it is manageable.
Exactly. It is manageable, but a lot of folks don't get that management aspect to it. They don't have the education. They don't have the support. They don't have the resources.
So at your center, what do you do for newly diagnosed patients?
Everything.
So you educate. You
number
do nutrition.
What we've found to be true is self-education is the biggest component. You just touched on something that's very, very crucial, especially for diabetics, and that's the diet.
Yeah.
We all know we should eat more vegetables. We all know...
Don't eat the Sundays.
Right. We all know moderation is
right.
really the element that we need to strive for, but we don't. As a society, we don't, at least in the U.S. So, for example, we talk to folks about their diet. We'll get them with a dietitian, somebody who's licensed, credentialed, educated in that field. In many, many cases, we'll work with the patient and their primary care doctor.
Yes.
To make sure that the patient understands, to make sure that the primary care understands. Essentially what we're doing is when we're sitting down with these patients and we're going through their health history and their situation, we develop a customized program specific to them and their situation, much like a primary care doctor who had time and interest might do.
Right. Or
a specialist might do, depending on the circumstance. So when we talk about our clinics, what we're doing is we're offering extra healthcare services that are easily accessible. And when they're used appropriately by the patient and with the primary care doctor's input or participation, people end up getting healthy or staying healthy.
And, it's funny because I don't think they really understand because they don't feel bad normally, especially hypertension, the silent killer, truly is.
Right.
Or diabetes. Well, I don't feel that bad. And they don't realize their blood's turning into slush and it's not flowing freely and it's not getting to the small capillaries. And then all the organs, vital organs are shutting down.
Yeah.
And that's what happens. That's kind of the issue with it. So, is it called Nifty After 50?
Yes, Nifty After 50.
That's a fun one. So the Nifty After 50 program focuses, you have people that will specifically work with you, spend the time with you, give you exercise, and they'll work with your lifestyle. You don't have to change who you are. Baby steps are the best. Make one little change at a time.
No, you're absolutely right. You know, I was watching a documentary the last 6 months about fitness, which was very strange. I don't normally watch these shows, but the reason I bring this up, this Scottish university professor had come to realize that there are certain genetic markers for different types of people that determine how successful they'll be in a fitness situation.
Oh,
if they're in the gym.
What show is this on? I want to see this.
I'll email you. I don't remember the name. But what happened was this guy had identified 11 different genetic markers that if a patient was flagged for these markers, they could then go and say, well, you need this type of fitness for your situation. This will work. This won't. What I came to realize is fitness, just like anything else, needs to be customized.
Yes.
You know, what's the standard regimen? We go 3 days a week.
Half hour a day, something like that.
Half hour a day.
You have to have your heart rate up for a half hour a day.
Well, that formula that we tend to know, we tend to have been taught is fine, but it doesn't work for everybody.
No, and it's so basic. It's just the most fundamental.
Right.
Get up and move.
I call it the common sense workout. So what happens with a gym like Nifty After 50 is the members get a customized plan specific to them, specific to their medical conditions, specific to their goals, their needs, and their abilities. And this is really, really crucial because the other component to working out at the gym you just alluded to. You know, I don't want to go to the gym where there's all these 20-year-old hard bodies running around and there's hip hop music and I can't hear and I got to wait for the weight bench and it's all sweaty.
That's me.
There's so many reasons people don't go to the gym. Right. With the Nifty After 50 programs, it is catered to the mature adult. It's designed for that patient population because what we know to be true is people who don't go don't get better.
Yeah.
So if we all know we should work out and we know it's best for us, yet we don't, let's remove those barriers that are causing us to not go.
And the best part is that you can get to know people your own age with your same backgrounds and common goals and maybe make some social groups and friends.
Or relationships. That happens a lot.
Yep.
But that's, you know, in summary, that's what makes us a little bit different. And that's a big thing we ask people to consider.
So my last question to you, and we're going to have to make it a quick one, so I know there's going to be more, and we're going to leave you dangling out there, population. What is the prescription help that's offered in these Advantage programs?
Wow. How much time do we have?
You literally have like 3 minutes.
Okay, let's go.
Let's go.
3 minutes. So Part D, it's also known as Part D, you may recall from last show. Part D is a standard benefit structure put together by Medicare in which all private companies who offer Medicare Advantage or prescription coverage follow. So in 2015, the way it works is you have $2,960 that you can use towards your prescriptions.
A year?
Well, we're not quite done.
Oh.
So $2,960. So everybody write this down. $2,960 is the amount of money that you start off the year with for your prescriptions. Depending on your program, you may have a deductible. Maybe you don't. Each company is a little different. But you start off with $2,960. Every time you get a prescription, either at a pharmacy or from a pharmacy in the mail, the cost that you pay plus the cost that the company pays is taken away from $2,960.
Okay.
So for simple math, let's say I have a $100 medication. I go to Smith's, I pay $30. My health insurance pays $70. That adds up to $100. That $100 is known as the total cost, and that is then deducted from $2,960. So now I have what, $2,860?
So you only have $246 a month.
We're not there yet.
Oh, sorry.
This is how you start the year, right?
Yeah.
So you every time you get a prescription filled, whatever your cost plus the company cost is deducted from the balance of that $2,960.
Okay.
So let's say we go through the year and I've used up the $2,960. It's gone.
Okay.
Then I enter what's called the donut hole. It's also called the coverage gap.
Boo.
Yes.
Yes.
It's okay. It's going away by 2020, just for our listeners. We can get into that maybe later. But I go from paying a copay or knowing what my costs are going to be to paying a discount. So instead of paying, say, $30 copay for a name brand medication, I'm now going to pay 45% of that cost.
You know what, Matt? This is a very detailed program, and I thought we could get this handled in 2 shows. But I'm seeing that prescription drug plans are, in and of itself, its own like a whole baby. Matt Engstrom with CareMore, I greatly appreciate this. This has been a wonderful education for me. This is Tina Drago with Healthy Las Vegas, coming to you from the Beasley Broadcast Studio A. Have a great day.